Hello everyone, this is Dr. Pritpal, an MD Pharmacology from CMC Ludhiana, and today I'll be talking about yet another topic which comes under the CBME curriculum of pharmacology with the competency number PH 1.13, where it talks about describe the mechanism of action, type, doses, side effects, indications, and contraindications of adrenergic and anti-adrenergic drugs. So I've talked about adrenergic drugs in my previous sessions. Today I'll be focusing on anti-adrenergic drugs, and to be more precise, I'll be focusing on two further topics, that is the adrenergic drugs acting on the alpha receptors labeled as alpha blockers, and adrenergic drugs acting on the beta receptors named as beta blockers. So I hope that this particular topic would give you some insight into how these particular drugs are effective in the clinical practice. And if there are any queries or questions, please get back to me right down in the chat box, and I'll definitely get back to you. So we start with this particular drug, that is, we start with alpha blockers. Now, when we are talking about alpha blockers, the first thing that we need to discuss about is the receptors. And when we are talking about receptors, there are two set of receptors that are there on which alpha, two set of alpha receptors that are present in the body, and these are alpha 1 and alpha 2. Alpha 2 are namely post-junctional receptors that are present on the effector organs, and they are present on the smooth muscles, thereby causing contraction. And if they are present on the smooth muscles of blood vessels, they cause vasoconstriction. They are present in the glands, enhancing secretion. They are present in the gut, causing relaxation. On the other hand, alpha 2 receptors are present on the pre-junctional nerve endings, and they are also present in the post-junctional nerve endings in brain, platelet, and pancreas. They are also cause inhibition of transmitter release. They cause vasoconstriction. They decrease the sympathetic flow and insulin release, and they cause platelet aggregation. Now, the alpha 1 receptors are further subdivided into 1A, 1B, and 1D. Why we are talking about these specific receptors? We'll be talking about it very soon. And similarly, the alpha 2 receptors are classified as alpha 2A, 2B, and 2C. The selective antagonist for alpha 1 receptor is prazosin, whereas the selective antagonist for alpha 2 receptor is yohamberin and ravolosin. Now, this is the effector pathway, that is the IP3 DAG pathway for the alpha 1 receptors to activate, and the cyclic AMP or decrease in cyclic AMP or opening of potassium channel is the pathway for the alpha 2 receptors. Now, these are when these receptors are activated via the neurotransmitters that could be adrenaline or noradrenaline. Now, what happens is now let's talk about the location where these particular receptors are present and how they are specific or non-specific to separate to some things that we are talking about. So this is the presynaptic cell where we have the synaptic vesicles. The alpha 2 receptor is present in the prejunctional cell, and the postjunctional are alpha 1 and beta 1 where norepinephrine binds selectively. Now, if we have the alpha non-selective alpha blocker, it will bind to both alpha 1 and alpha 2, whereas the non-selective alpha 1 receptor will only block the postsynaptic receptor, and the presynaptic receptor would be open up. So this would even block the negative feedback, thereby it would lead to further enhancement or problem in the patient. Now, when we talk about these alpha blockers, before I go into the drugs that are there, they cause a fall in blood pressure. How do they do that? Well, we talked about this particular drug, alpha 1 receptor being present in the smooth muscles, and even the smooth muscles, they tend to cause, in the smooth muscles, they tend to cause contraction, vasoconstriction. Vasoconstriction leads to increase in PPR. Now, when you block these receptors, the tissue peripheral resistance fall. This fall in tissue peripheral resistance leads to decrease in venous return and cardiac output, leading to fall in blood pressure. Sounds very interesting, but because of decreased venous return, our body tends to compensate it with reflex tachycardia, and it causes peripheral cooling of blood, thereby it leads to orthostatic hypotension, which could lead to interference with postural reflex. Few more actions that are there with alpha blockers are the alpha receptors are present in the smooth muscles in the trigone of the bladder. Now, these particular alpha receptors, they increase the tone and constrict the sphincters. Once you give alpha blockers, the tone is decreased, the sphincter is relaxed, and the urine flow improves in the benign hypertrophy prostate patients. It tends to inhibit ejaculation. Again, it tends to cause nasal stuffiness because it is causing vasodilatation. It tends to cause meiosis because it blocks the alpha receptor present in the radial muscle of the iris, and it tends to increase the intestinal motility. Further, these particular alpha blockers can also decrease the renal blood flow due to hypotension, and this leads to a decrease in GFR. Now, these alpha blockers, now we are not generally, when we talk about alpha blockers, we are mainly concerned with two major organs where we talk about this. One is the blood vessels, that is this one, and the other one is the trigone of the bladder that we are talking about out here. So when the alpha receptors are activated, you see those green marks. These are agonist binding to the alpha receptor, leading to vasoconstriction and contraction of the smooth muscles. So this bladder is constricted, the sphincter is constricted, and there is difficulty in flow of urine. You give an alpha blocker, it binds to this particular receptor, causing vasodilatation out here, and it binds to this receptor out here, that decreases the tone of the bladder, and if this decrease the tone leads to a smooth flow of urine. Now, coming to the classification of these drugs are classified into two categories: the non-equilibrium type and the equilibrium type. So the non-equilibrium type or the irreversible type are beta-haloalkylamines, where the classical example is phenoxybenzamine, and the equilibrium type are non-selective, which could be imidazoline, such as phentolamine or tolazoline. They could be alpha-1 selective, such as prazosin, terazosin, doxazosin, tamsulosin, and efruzosin, or they could be alpha-2 selective, such as yohimbine. There are a few more drugs that could act as non-selective alpha blockers, though they are no longer included in the classifications. These include the ergot alkaloids, which include ergotamine and ergotoxin. There are hydrogenated ergot derivatives such as dihydroergotamine and dihydroergotamine, and there are some miscellaneous compounds such as chlorpromazine that also have alpha blocking property. Now, where do we use these alpha blockers? So these alpha blockers are mainly used for two basic conditions. One is it is used in pheochromocytoma, and the other one is it is used in benign hypertrophy of prostate. We'll come to the reason why we are talking about this. So first is for pheochromocytoma, we tend to use phenoxybenzamine, and for hypertension, it is one of the drugs of choice if patient has BPH also, and you could also it could also help in relief or control episodes of rise in BP following an alpha-2 agonist withdrawal. It could be used in benign hypertrophy of prostate. It could be used in Raynaud's phenomena, because in Raynaud's phenomena there's vasoconstriction, so it causes vasodilatation. And it could also be used in secondary shock, where we tend to give IV phenoxybenzamine. Now, coming to the one of the major uses of this particular alpha blockers, that is the non-selective or non-equilibrium time. We talked about pheochromocytoma, where we are talking about phenoxybenzamine being the drug of choice. Now, when we talk about these catecholamine producing tumors, there is a neuropress. Neuropress leads to control the sympathoadrenal progenitor cells, which leads to formation of neuroblastoma, or it could further lead to chromaffin cells and sympathetic ganglion cells. If there is growth of sympathetic ganglion cells, it's ganglioneuroma, and if there is chromaffin cells, whether intraadrenal or extraadrenal, it could lead to pheochromocytoma. So what happens in this? In the normally, what happens is the catecholamines are produced by the amino acid tyrosine under the influence of enzyme tyrosine hydroxylase. It gets converted into L-DOPA, and L-DOPA is further converted into dopamine. This dopamine is degraded by MAO inhibitor or COMT inhibitor into homovenilic acid, and dopa beta hydroxylase could further convert dopamine into norepinephrine, and norepinephrine is further converted into epinephrine, being acted upon by COMT and MAO inhibitors, causing release of normetanephrine, metanephrine, and vinyl mandelic acid. Now, what are the clinical features of pheochromocytoma? The pheochromocytoma is, as I've already told you, is a tumor of the adrenal medulla. It causes an attack of headache, respiration, palpitation, and anxiety. It causes hypertension, and there is paroxysmal rise in blood pressure. It leads to elevated urine catecholamines and their metabolites, which we talked about: homovenilic acid, methyl vanillic acid, metanephrine, and normetanephrine. Phenoxybenzamine is one of the drugs that could be used, but though for pheochromocytoma, treatment of choice is to undergo an operative procedure. Now, in this particular silphenoxamine cyclizes to ethylene minium intermediate, and this causes blockade of alpha receptor. It could be used as both inoperable and operable pheochromocytoma, and it could also be given for as IV infusion during surgery so as to prevent spillage of the markers. Another indication where these particular drugs are used are benign hypertrophy of prostate or benign prostatic hypertrophy. So this benign hypertrophy of prostate is a non-malignant enlargement of the prostate gland. Now this is caused by cellular hyperplasia of glandular as well as stromal element, and this leads to troublesome lower urinary tract symptoms in men. Now this is one of the most common benign tumors, and it is not a precancerous condition. Now, what it does is we talked about that this particular thing leads to lower urinary tract symptom. Now, these lower urinary tract symptoms could be of two types. They could be voiding or obstructive symptoms, or they could be the other type. So, the voiding or obstructive symptoms include uh, hesitancy, intermittency, incomplete voiding, weak urinary stream, straining to pass urine, prolonged micturition, and terminal dibbling. Whereas the other could be storage or irritative symptoms, and this could be frequency of urination, nocturia, urgency, urge incontinence. Now, if we talk about the normal physiology, when we talk about a healthy human prostate, it is slightly larger than the walnut, that is around 4 centimeter by 5 centimeters. It surrounds the urethra. So this is where it is. If this is located and can be felt during rectal examination. It has anterior, median, posterior, to lateral lobe. Now these are the relations. Posteriorly, it is related to rectal ampulla, the tenovirus fascia. Superiorly, it is bladder neck. Anteriorly, it's the pubic symphysis and or the retropubic space of Retzius, and inferiorly to the urogenital diaphragm. And it works is regulated by androgen, which are responsible for male sexual characteristics. This is further differentiation of this. Now, this particular component, this particular disease has two components. One is the static component, the other is the dynamic component. Static component is due to an increase in the size of gland, whereas the dynamic component is due to increase in the tone of prostate and urinary bladder or neck smooth muscles. So the alpha-1 selective drugs, they tend to act on this particular dynamic component. They decrease the tone of smooth muscles, thereby helping treating the obstructive symptoms. So in this case, we have reversible drugs, selective alpha-1 blockers. We could use short-acting prazosin, we could use long-acting alpha-zeusin, doxazocin, terazosin, or tamsulosin. All these drugs have a side effect of dizziness, postural hypertension, fatigue, retrograde ejaculation, rhinitis, and headache. And there is always a possibility of first dose hypotension, so it is always advisable to give alpha blockers at bedtime. Terazosin and doxazocin may further decrease the total cholesterol as well as LDL fraction, and they cause first dose syncope, so titration is required. Alfuzosin and tamsulosin are selective alpha 1A, and in this case, dose titration is not required. Now, what happens if we give tamsulosin, which is an alpha-1A selective blocker? So, alpha-1A selective blocker, that is tamsulosin, if it is given in normotensive patient, it does not have any effect on the BP, and it has no orthostatic side effect. It can be combined with with nifedipine, enalapril, and atenolol. So there is no change in the pulse, and there is no additional side effects associated with this particular drug. So it is always advisable to go for a selective benign hypertrophy of for a selective alpha-1 blocker for benign hypertrophy of prostate. We generally don't tend to use alpha blockers in hypertension because I told you that it causes orthostatic as well as postural hypertension, and it further leads to reflex tachycardia, which could further increase the workload on the heart. So this finishes the topic on alpha blockers. If you have any questions or queries, you can put it in the chat box and I'll definitely get back to you. I hope I have been able to clear some air on this particular topic. And till that time, have a good, nice day and a happy learning experience. Thank you so much for your patience here.